The meeting of the Health Insurance Reform Commission shall come to order now. And can you call the roll?
Delegate Ware.
Here.
Delegate Byron.
Here.
Delegate McNamara.
Here.
Delegate Sullivan. Senator Serville.
Here.
Senator Saslaw.
Here.
Senator Spruill.
Here.
Senator Barker.
Aye.
Secretary Littell.
Here.
Commissioner White. You have a quorum, Mr. Chair.
All right. Well, we have several things today, so we'll get started right away here. Julie, can you come up and talk about the essential health benefits benchmark plan, and where we are on that whole process that we've heard a good bit about?
Yes, absolutely. Good afternoon, Mr. Chair and members of the Commission. My name is Julie Blauvelt. I'm the Deputy Commissioner of the Life and Health Division at the Bureau of Insurance, and I'm coming back to you to talk about the Essential Health Benefits Benchmark Plan. I was here several months ago, right after the legislation passed, and now I'm back to give you a little update. So let's see. Okay, so today I just want to, like I said, do a little review. I think everybody here is pretty familiar about what essential health benefits are and the requirements for that. We'll talk about the legislation that was passed this past session related to the essential health benefits requirement and the benchmark plan. Give you an update, like I said, on the application. Talk about how HERC's review process will change as a result of the legislation, and also the review of the next essential health benefit plan, benchmark plan. All right, so back in 2012, when the ACA required all states to set their essential health benefits through a benchmark plan, there were default plans that the federal government said states could choose from. Virginia did choose the default plan in 2014, which is the first benchmark plan we chose, and then again in 2017 when CMS said states had to update their benchmark plans. And again, we chose the default plan. That was done by a letter from the governor to choose those default plans, and that sets the essential health benefits, or the benefits that plans in the individual and small group markets are required to offer. And so it does not affect the benefits that are required in the large group market. The individual and small group markets make up about 660,000 covered persons right now, which is about 7.5% of Virginia's population. So each state chose or defaulted to their benchmark plans back in 2014 and 2017. And under the ACA, the reason for needing to choose a benchmark plan is because the federal government pays tax subsidies. They pay for the coverage, the essential health benefits that are covered for people in the individual market that buy qualified health plans, and to some extent people in the small group market as well. So when a state sets the benefits that are going to be in that plan, the CMS doesn't want the states to keep adding on benefits since the federal government is paying for those. So what they said is, if a state does want to mandate benefits through legislation, then the state will need to pay for that portion of premium that is above what the essential health benefits benchmark plan is set at. The other option, and how states can change their essential health benefits, is through an application process, which is the legislation that went through last session to set what needed to be included in the new essential health benefits benchmark plan for Virginia. And that is the plan that we made for 2025, or that we submitted an application for 2025. There was legislation recommended by the Health Insurance Reform Commission that wanted to add certain benefits to the current benchmark plan. So that was the application that we did. The application was posted on our website, and We had a public comment period, which is what is required through the application process. We submitted the application by the deadline. CMS came back in the review process with a couple questions, but nothing much, and the application was approved last month. So Virginia will have a new essential health benefits benchmark plan for plan year 2025. And the changes to the benchmark plan, so it'll include everything that's in the essential health benefits benchmark plan right now. But it also adds in two benefits that were specifically requested. One is the expanded prosthetics devices and components, which is right now just mandated in the large group market. So we have prosthetics and components in the benchmark plan, but this will be expanded, what's considered to be medically necessary prosthetic devices. We also added the formula and enteral nutrition benefit, which again, we had a piece of it in the current benchmark plan, but it's expanded to include oral nutrition and when the need for the nutrition isn't the majority of the nutrition needs. So those were added. While we were updating the benchmark plan, we changed some wording in the benchmark plan because some wording was out of date for MAPIA requirements and non-discrimination requirements, and updated the preventive services that are now required, and also included some mandated provider provisions that have been passed by the state up to that point. So that was all part of the EHB benchmark application that has been approved for 2025. So the legislation also created another step to the HERCS review process. And this was part of the legislation. So a state mandate that applies to QHPs, that automatically will kick that benefit out of a benchmark plan now. A state can add a benefit by a mandate, but again, the state would have to pay for that benefit, which is what we saw when we had hearing aids mandated. That will be effective 2024. The state will be defraying those costs at a rate of, I believe, probably 10 cents per member per month for that coverage. So if mandates are chosen, for the individual and small group markets, qualified health plans, the state will need to pay for those mandates. But there's another way that states can add benefits without mandating and having to pay for them, and that is by updating the benchmark plan, which we've done. So the new step that's added to the HERC process is that in addition to HERC sending something for a step 2, if we say that this is considered a mandated benefit after the step 1 process, HERC can look at that benefit and say that they want us to study it further to look at it being added to the benchmark plan in the future instead of having it be a new mandate. Or there are a lot of other options. It can still be a new mandate, but maybe only apply to the large group market, which doesn't affect the individual and small group market essential health benefits.
Mr. Chairman, could I ask her a question at this one part? So you mentioned that there's a lot of different ways, which is true. Someone will always figure a way to get around something. But when you talk about the putting it in the essential health benchmark plan, that it doesn't cost the state anything then, but it still raises the cost of that in those insurance plans. So it still does actually cost. It's just not a separate cost that covers all the other areas.
Right, the state is not defraying that part of the premium. So the federal government is paying for the premium for that plan, for qualified health plans. Whereas when it's a state mandate, the state would be paying for that portion of premium.
But doesn't the state use the essential health benefit plan basically as their basis? Don't we kind of mirror that? No? Yes, no?
I'm not quite sure I understand your question, but
That's all right. It'll come later.
maybe,
Thank you,
maybe,
Mr. Chairman.
are you saying that the mandates that are already in Virginia law are part of the benchmark plan already?
I'm just saying something is going to cost somebody something when you make it nicer.
Right.
Somebody's paying for it.
Right, and the federal government does have parameters for choosing a benchmark plan. There are top parameters. So at the beginning of the ACA, a state has 10 choices of different types of benchmark plans. One is a federal employee health plan. So when we're submitting the application, we have to let CMS know that the benefits, the increase in benefits are not any more than what our most rich plan is allowed to be under the CMS requirements. And that's part of the reason why states need to submit an application for a new benchmark plan, so that they can look at the calculations and make sure that it still is in the realm of being a typical employer plan, and it's not outside of that premium. Okay. So we talked about that. I want to kind of, I guess, get a little bit more specific about a mandated benefit versus a mandated provider bill or a mandated cost-sharing bill, because CMS has been specific that those are mandates that they don't consider to affect essential health benefits. So if a state wants to mandate those types of things, that doesn't need to be part of the essential health benefits benchmark plan, and there's no defrayal of cost. So you'll see when the Bureau of Insurance goes through its step 1 analysis, we'll identify the mandates that we view as being benefit mandates versus provider mandates versus cost-sharing mandates, because that makes a difference as to whether one of the options for HERC is to consider that as an addition to the EHB plan, or as a state mandate, with the possibility of a defrayal. So that option, or the requirement to defray costs or to have to add it to the benchmark plan, is not there for a provider mandate or a cost share mandate. Okay. I think I kind of talked about the options, and you'll see in the step 1 analyses that we'll be recommending options that HERC could choose. I think, a step 2 assessment could be a good idea, whether you're wanting to recommend the benefit be added to a benchmark plan or whether it's recommended as a mandate. And then there's the option of only applying a mandate to the large group market, or through our step 1 analysis, we may find that the benefit is already covered by most plans, and HERC may feel that no legislation activity is needed.
All right. Thank you. Are there questions or comments? Yeah, go ahead.
I just have one more slide that talks about the new review process. So there were 2 pieces of legislation. One told us what was going to be added to the benchmark plan for 2025, and the other is an ongoing review process, so that there's something set up for the state to regularly review the benchmark plan and possibly make changes. And that process will start again in 2025 with HERC's review in 2025. The Bureau of Insurance will start the process next year sometime with a working group of stakeholders that will take a look at the analyses that we presented to HERC. That will be in a report that we give to HERC at the end of March 2025. And when we did the comment period for this last benchmark plan, we got a comment from the Virginia Poverty Law Center that we should also be looking at the data and complaints that we see coming through to maybe have some additional ideas about what might be considered in the next benchmark review. So that we'll talk about that in the work group as well. We'll have that report by the end of March 2025, and then HERC will be holding 2 meetings. According to the legislation, HERC will need to hold 2 meetings by the end of June to think about what changes may be needed to the benchmark plan, and to ask the Bureau of Insurance to maybe do some more intense studies about what the costs will be for adding those benefits to the benchmark plan. When I say costs, I'm talking about addition to premium for consumers, adding those benefits to the benchmark plan. And then HERC, when we come back with that information for HERC, 2 more public hearings are required under the regulation, or under the legislation, if HERC wants to move forward with new benefits. And so that decision will come at the end of December of 2025. So just to quickly recap, we did get approval for the 2025 benchmark plan with the expanded benefits. HERC has a new process. They can, a new option for mandates that HERC is reviewing that can ask for it to be reviewed under the EHB for a new EHB benchmark plan. And starting in 2024, the Bureau of Insurance is going to start with a working group to look at the recommendations HERC has passed on for that EHB review process, and start the new review for what will be a new 2028 benchmark plan if that's what HERC decides. And that concludes my presentation. Are there any questions?
Mr. Chairman.
Any questions? Yes, Senator Searle.
Thanks, Mr. Chairman. My recollection is as the bill went through the process last year, that on the Senate side, we added some language. I think it was requested by the Poverty Law Center, which I think it was in the same vein of what you just spoke a moment ago, but I want to say there was like 4 or 5 different variables that they suggested that we look at going into the next review process. And I remember that came out in conference because it was different than what the bill that we had sent out of here. But Mr. Chairman, I thought we had talked about like a letter from you, like referring to this body to look at those 5 variables to see if that is something we ought to add. I remember during the legislative process, we felt like we didn't have time or didn't want to look at it as part of that because we'd already agreed on a bill. But we had thrown that issue back to this commission to look at going forward. And I mean, I thought it was kind of worthwhile stuff to look at. It was, you know, how many benefits are being used and what's being rejected and the cost. Anyway, I don't. You probably remember what I'm talking about.
I do recall that, yes, and I do recall that. I think the Bureau of Insurance had asked for some more specificity as to what the work group should look at, and I think you're right that it got probably removed from the bill, but the Bureau of Insurance could take that on if you know, based on the comments that were received. It's probably not a bad idea to be looking at that information, and there is additional information that we need to look at too, other than just the recommendations. So,
So, Mr. Chairman, I don't know if that's for. I think it's probably for a future meeting or something to tee up whether or not we ought to look at adding that to the. I mean, the process doesn't start till 2025, so we still got, some time to do it, right? But I think that needs to be on the agenda at some point. Just to look at.
We can certainly do that. Just put it on a future agenda. So, all right. Any other questions? Any other comments on things? All right. Well, thank you very much.
Thank you.
And we will now move to step 1 assessments on referred bills. Start with Van Tompkins. So.
Good afternoon. On the chart, my bills are, there are two before mine. Mine's listed on page 2. So either Brad can go, huh? Oh, that's all right.
Okay, go
So
ahead.
Brad can go first, so we can start with 1815. That's absolutely fine. I'm Van Tompkins from the Bureau of Insurance, and I have 2 of the bills on your chart, starting at the top of page 2. House Bill 1815, which is mandates coverage for diagnostic and supplemental breast examinations with no cost sharing. That means no out-of-pocket, no coinsurance, no deductibles for the person receiving the tests. Screening mammograms are covered today very broadly by the carriers, both because they're part of the essential health benefits and also because they are part of preventive care services. And carriers tend to cover screening mammograms, according to our survey. They tend to cover them with no cost sharing, even if the person does not necessarily is, age 50. It's an annual screening that's available, but they tend to cover them without cost sharing, kind of regardless of the age, for people who are younger than that, if it's necessary to have them. What this bill wants to mandate is no cost sharing for the other types of tests, that once a screening mammogram has identified an abnormality, then there could be a breast MRI, there could be a breast ultrasound, or even a diagnostic mammogram. Any of those tests, the proponents had hoped to see no cost sharing for those either. And the carriers routinely cover all of these tests, but beyond the screening mammograms, there's typically cost sharing associated with the next level of tests. As a result, we do believe that CMS would see this bill as a mandate, and that offers several options which are in the last column on your right on the chart. Obviously, there is the new essential health benefits process, and this bill could be referred for that. This bill could also be the subject of a Step 2 review. Both of those would work. It could also be enacted, as it is, just as we did with hearing aids, which means the Commonwealth would defray the cost, or, as we've discussed in the past, if you apply a new mandate just to the large group market, then there's no cost defrayal for the Commonwealth. And one recommendation I think that HERC might also want to consider is, since these tests are covered by carriers pretty much across the board today without a mandate, then if the bill were to be revised to just remove cost sharing from diagnostic and supplemental breast exams, the same thing is accomplished. That they are, I believe that's what the proponents are looking to do. Any questions on the breast exam bills?
Yes, Mr. Chairman.
Delegate Byron.
I want to make sure that, I'm sure I'm not the only one that doesn't understand some of these details that you're talking about here, so we're clear. So, you said that we have all these different options. For example, we could consider no action because carriers generally already cover these services. And what I'm getting at is, I know as chair of the committee that I got a lot of bills that people bring forward, and sometimes they are or are not aware that they're already covered. And we generally just try to tell them that, or they want to do it anyway and they get sent to HERC. So when we have some of those, the question is then going to be that we don't have, if we feel that they are generally covered, then HERC does not have to recommend them going to a next step, or what is that? And then all the other things you're considering, isn't that for the legislator to come back and put a new bill in, or was that already in the bill?
I think when we wrote this, what we were thinking was, if you did not want to recommend it for step 2 or for the new benchmark plan process, and I know that Mr. Gray could speak to the fact that the carriers cover a lot of this already, which they do. This would be a candidate for a recommendation by HERC, maybe in the final report of the year, that, we consider the patron might want to streamline the bill to just accomplish their goal by simply, saying no cost sharing for these types of breast exams. And that would do it.
Mr. Chairman, follow up?
Yes, Delegate Byron.
So there's a couple things that go through my head with that now. So you said that they could streamline the bill. One, they did actually talk about no cost sharing, and even though the carriers normally cover these, I know even some of the plans, they cover them with a percentage. So if
Cost sharing is common with these other tests.
if they change their bill and refine it next year without us looking at what those costs are in the next step, won't it most likely get sent back again to the committee to look at?
Tom, if it's strictly a cost-sharing bill, what do you think?
Mr. Chair, Doug Byron, I think you all did add cost-sharing changes as a requirement for bills to go to HERC a couple years ago in the definition of mandated benefit. This bill's already here, so I think it would be up to the committee to hear it.
Senator Sasslaw.
We don't need a new bill. If we just pass this, that would eliminate the cost sharing in the insurance process for breast cancer, correct?
No, it would take it to, Mr. Chairman, sorry, Senator Sassel, I think it takes it to step 2 is what we're approving, aren't we? Taking it to the next step? Is that correct or not?
Mr. Chairman, I think that's what Van was saying. Y'all could take it to a step 2. You certainly could also kick it to the EHB benchmark review process. If you all want to examine the bill just as eliminating cost sharing, I think the delegate was maybe proposing that if she didn't, if Mr. Chair, Delegate Simmons would want to speak, I'm not sure.
All right.
Mr. Chairman, who brings out the cost? That's all I want to know. Isn't there a step where you come back to us with the cost?
Step 2.
Right. So that would be where a lot of the interest of, I would think, committee members are now, minus Senator Sassel, who might be ready to vote on this today. I am saying, generally, I would like to see what the cost of something is.
Yes, Senator Sasslaw.
I would say to Delegate Byron, in my lifetime, I've lost count of all the women I've known who've had to deal with this. A lot of them could probably afford the cost sharing, but there's a lot that probably could not. And this, I mean, you're talking about 50,000 women a year dying from this. And quite frankly, if this will encourage, the early review of this, it might save an awful lot of lives. That's why I don't have a problem with this. Just change it to make it, cost-sharing bill, exempting that breast cancer and all aspects of it from cost sharing.
Delegate Simons, do you want to weigh in on this situation?
Thank you. Speaking to the bill. What I would really love is to have the bill released from HERC so that we can introduce another version. We've gotten some really good feedback from the Bureau of Insurance for language that will make it clear that this is about cost sharing. And I think a new bill would actually answer Delegate Byron's question about it having a fiscal impact and being able to look at that. So that's really where we are right now. We've been working on a new version of this, and we're hoping that the new version will not need to come back to HERC.
All right, are there any questions of the patron of the bill? So would you prefer it going to step 2, or to have it just go back, take it back in essence, and then figure out how you would do a cost-sharing situation or anything else?
Yeah, I think doing a new bill that is crystal clear that this is about cost sharing is what we would like to have it released from HERC.
All right, well, then I would guess that then the motion would be that we would not have a motion there, and this can sort of lay there right now, and then you could be in position to be able to present a new bill in 2024.
Mr. Chairman?
Yes.
So if it lays there, wouldn't it still be in our hands? Why can't we just get rid of it? If it just lays there, you could bring it back at some time. So I'm saying, so if you just doing what you suggest, just let it lay there, then it's still under us. So why can't you just get rid of it, and that will let her do the next one? I just can't understand why you just letting it lay there. You got to do something with it.
We don't have, I don't think we have to actually vote for something. We certainly could vote for step 2 process, which would do the calculations of the costs and how we would be able to support that. And that we can do that, go at that process. But if we don't do something like that, then I think that it can go back to the patron in this particular situation to be able to work a different bill that would be a little tweaking of it. Is that reasonable, Mr. Stevens?
Yes, sir, Mr. Chairman.
All right.
Yeah, I would think that would be the best way to go, because we've gotten some very valuable feedback from the Bureau of Insurance on how to word this properly, and I'd like to do a new bill number and just submit a new draft.
All right. Well, if
Mr. Chairman,
Yes,
just for future bills, I think, or maybe this is for Mr. Stevens, don't we have still with the process 2 years? So if she lets this sit here, that gives her the time to do her bill too, and the bill is just not, the Bureau isn't spending time on language that may not be effective. Correct? Tom?
Yes, ma'am. The Commission's given a period of 24 months to complete its assessment.
Mr. Chairman?
Yes.
Well, my concern, if this lays there, my concern, I just want to make sure that someone on the commission can't bring it back if it just lays there. So if it landed, it's gone. My point is, you're going to bring in a new bill. But I just want to make sure that what is here right now, if it just lays there, that Dick Saslow or Scott Survey next month can bring it back again. So I just want to make sure that we can't touch it no more. Let her do her new bill. That's all my concern was.
They wouldn't do that to me.
that's right.
They're politicians, you know that.
All right. Any other comments or questions? Or does anybody want to make a motion? All right. Well, if there's no motion, then
Wait a minute, Mr. Chairman. So,
yes, Senator's rule.
my question, do we need to make a motion to do what I'm suggesting to help her out? Just don't do nothing at all. Do we need to make a motion to the problem bill to just lay it on the table, do it, let's do away with it? I don't want to do anything at all. I just want to make sure that this bill is gone and the new bill come forward. That's all I'm trying to do. So do we do that? Do nothing? We make a motion that it's just laid on the table.
Yeah. I mean, we can vote if you want to make a motion to that effect. That
I so move.
that-
Whatever it is Tom
right.
said I have to do, I do it.
Yeah, so we've completed our assessment here of this without any recommendation.
Exactly what our
And is
motion,
there a
whatever it
second for the,
is.
for the,
Right.
okay, we have a second there. And then that would put it so that it's not something that somebody would say, well, it's sitting there.
Okay.
And we need to act on it, so, even though we don't. But anyway, we could do that. So if, I guess if there's no other questions or anything, we can vote on the bill. So any further questions? All right, all in favor, say aye.
Aye.
All opposed, no. All right, the bill is, disappears, I guess is what happens there, so.
Okay, I appreciate it.
Yeah, so.
Yeah. Thank
And
you.
you can
to
bring
the
it back
committee.
next year, so.
Okay. Thank you, committee.
Certainly. All right,
I have one more bill to discuss, and then my BOI teammates will also have some on the chart. This
Right.
one should be top of page 3, House Bill 2206. There it is. Okay, it starts on the bottom.
Bottom of page 2.
Page
so-
2.
Right.
House Bill 2206 deals with proton radiation therapy, which is used for the treatment of certain cancers. This is an issue that HERC did look at several years back, 2018, I think it was. This particular bill states that if the patient's treating physician or the radiation oncologist recommend proton radiation therapy, or if it's covered by either Medicare or Medicaid for this particular type of cancer that the patient has, then the health carrier must consider that as sufficient evidence to provide coverage. Virginia's current benchmark plan and the revised benchmark plan for 2025 both contain radiation therapy generally. It does not exclude proton radiation therapy, and it does not require it either way. As a result, CMS, who did actually look at this bill for us, indicated that because the carriers must pay if the treating physicians recommend it, then it is a new mandate. So this one is also a new mandate. The carriers today do cover proton radiation therapy for certain cancers. I believe pediatric cancer is a good example, possibly cancer of the esophagus. And if a treating doctor does recommend proton therapy, then the carrier will consider clinical evidence to try to determine if the proton therapy has shown to be effective for the type of cancer that this patient is dealing with. So as a new mandate, just like before when we were talking about breast cancer, we have the option of the step 2 process. We also have the option of the new essential health benefits benchmark plan process. You know, this also is another one that could be limited to just the large group in order to defray costs for the Commonwealth. And finally, this one could be enacted as a mandate, just as we do with hearing aids. And then the Commonwealth does have to defray the costs. So that is the story on House Bill 2206.
All right, are there any questions on this particular bill? This one that was dealing with proton
Radiation
radiation
therapy.
therapy. And in Virginia, there is a proton radiation service out of Hampton Institute.
Yes.
And so that has been there actually for a number of years, and was sort of was the first one that was adopted in Virginia. And it was used initially without reimbursement from most of the insurance companies because it had not been authorized through Medicare and those types of things. And it was also limited by and large for several years principally to prostate cancer. And that was a cancer that they had determined where there was benefit to trying this in many instances. What's happened now is that there is I guess it's probably been a little over a year and a half anyway, at Fairfax Hospital in Northern Virginia. And that they have installed a proton radiation therapy unit. It is absolutely massive. It's like over like a 4-story building that they had to use to put it in there. It is close to $100 million in terms of basically getting it up and operational, but it has been used in a number of situations now, so that there is some use of it, and it goes well beyond just the prostate cancer that had been where it had been implemented previously. There are a couple of others that are looking at things right now, but I don't think there are any others that are already in place at this point. So it is extraordinarily expensive, and because of just the capital costs that had to go into these operations. So, Delegate Byron.
Yes, could I ask Doug Gray to come up a minute and refresh a memory here? I mean, this is one that has been before us for many, many years. And as you stated, and it's nothing to do with whether or not the therapy is good. We've heard a lot of good things about proton therapy. And as you said, there's other facilities now that are offering it as well. And this seemed to be just one facility that had an issue, because I understood that the others were covering it. So can you help me remember what the issue is here?
So the chairman is correct that there are more facilities now than there used to be. So Hampton was the first, but now Inova has one, and there are several in the DC metro area as well. The real issue that I think the advocates have brought is that they would like common procedures like prostate cancer to be regularly covered with proton therapy, when there are other therapies that are more effective and more cost-effective as well that are offered at the hospital, which are like intensity modulated radiation therapy, which is the common approach for prostate cancer. So, their costs are much higher. Their results aren't that much better. So what that means in the clinical world is that it's not recommended as a clinically effective approach versus what's offered with IMRT. So that's the practical reality. So they'll say things like, well, we cover it for Medicare. Well, if they charge the price that they would pay under Medicare in the commercial world, there might be a different discussion. If there was parity between IMRT and proton therapy in terms of price, and people were agnostic about, not only the price but what they recommended, then there'd be a better clinical discussion about it. But at this point, it hasn't progressed to that point where it's a commonly accepted practice for that particular procedure. Other procedures, it's demonstrably better. The clinical evidence supports it. So like if you're trying to do something with cancer around the eye, with pediatric cancers with certain tissues, totally in agreement that that's an appropriate approach and it's covered. So it just depends on, on the procedure.
Mr. Chairman?
Yes, Delegate Byron.
So are some insurance plans covering proton therapy?
Some may. In some circumstances, it depends on what it's for. So for prostate cancer, it's not commonly covered,
right,
or routinely covered. For other things, sure, it is. And that's what she was listing.
Is this specific for prostate?
Well, that prostate was where they started out.
Yeah.
But Mr. Gray there is accurate in terms of what my understanding of the situation is. But that prostate is actually, it's not used regularly for prostate. There have been some instances where they do, but not anywhere near what was anticipated a couple of years ago from some of the proponents of this. And it's used in a number of other situations. And one of the things one of the situations is a lot of children who have cancers that are significant and are potentially lethal. They can actually use the proton machine and get at least as good, if not better, coverage for the place where the cancer is, without having it, having the radiation bouncing around and doing damage because of the children being vulnerable and also hopefully having a long life out of that and not getting cancer somewhere else. So.
Yeah, and look, don't get me wrong. If you are extraordinarily wealthy and you want to pay out of pocket, you can use proton therapy for prostate cancer, and many people choose to because they can afford to. But that is not the clinical, process at this point, and that's the challenge. And remember, proton therapy is multiple visits with a massive infrastructure. IMRT isn't. And that's the difference. And IMRT is prevalent. What I never have is a conversation where the hospitals actually talk about what they do and how much it costs in comparison and what its quality are. That they usually just, that's your problem, Doug. See ya. And I get it. I mean, it's not fun to talk about things like this. I mean, they're challenging.
Mr. Chairman.
Delegate Byron.
So wouldn't a step 2 be helpful in getting the information we need to confirm what you're saying? And, because this bill's going to keep coming back, I can assure you.
Mr. Chairman and Delegate Byron, and no, it's not going to help because it's the same thing that we've done every other time, which is they want to charge whatever they want and they want us to pay it. And that's not going to happen.
That won't come out in a step 2?
I mean, in the end, the reason this isn't happening is there's no parity between the competing process that has the same result.
Well, that's, I think, is the case for the prostate, but
For
actually
prostate, but not for the others.
Some of the others.
Yeah.
And so actually, I think by having this go to a step 2 process, that way we would get the comprehensive information of how much it costs, what the charges are, and what the reimbursements are, because they are occurring now, and Medicare has certified that. And there is a lot of opportunity to get information, and it would help us in terms of figuring out, other than children, what are some of the other issues that are potentially beneficial where this would be there.
So one thing you'd have to know is the frequency, how often it would be used.
Right.
Because you're not going to be able to figure out what your total cost is if you don't. You're going to have to figure out how much it's going to cost the state health plan, which would have to do it if you're going to do it in this case. Then you're going to have to figure out what your impacts are on the individual and small group market, because this is going to be an addition. And I do believe there would be a cost that would have to be defrayed as well. So, in essence, you've got 3 line items you've got to deal with. It's a big
I'll
ask.
remind everyone, there's only going to be, I think, if they make it, only 3 legislators at this table that will know that information next year. So I think it would be very helpful for us to consider a step 2.
Step 2 would be good, probably a good thing. You want to make a motion for step 2?
Can I go?
Yes, thank you. Unless the Bureau had something else to recommend, I would make a motion that we consider step 2 with all the information that would be beneficial to people to understand this mandate.
Yeah, step 2 would give, the financial costs, the social costs, the impact on health insurance generally, and the medical efficacy.
Right.
And that would be JLARC and BOI in a deep dive into this bill.
Right.
Mr. Chairman, question.
Is there a second?
A second.
Okay, we got a motion, a second, and
Question.
yes.
Can I ask a question?
Yes.
On your step two, do you do it where we are from a relative standpoint with other states? Is that part of that analysis?
I think, Julie, don't you think that in JLARC's analysis, I believe, yes, that between JLARC and BOI, looking at different parts of it, I do believe that's covered. It's been a couple years since I looked at one, but I think so. I believe we do.
Thank you. Thank you, Mr. Chairman.
Absolutely.
All right, are there any other questions or comments? Okay, we have a motion and a second to send this to a step two process. If there's no further discussion, all in favor say aye. Aye. All opposed, no. All right.
Step two.
Yes, step two will do.
Okay.
Yeah.
The first bills on the chart are Brad Marsh's bills, and the other bills are Garth's shipments. So either way you want to, either direction, move up the chart or down.
Well,
To cover.
on my list there, Brad is number 2.
Okay.
Good afternoon, Mr. Chairman, members of the commission. I'm Brad Marsh, a policy analyst or policy advisor with the Bureau of Insurance. I've got 2 bills here at the beginning. I'll try and run through them pretty quickly because neither of these end up being actual mandated benefits. They just address cost sharing with benefits that are already currently mandated. The first bill up there is House Bill 477. It addresses coverage for prostate cancer screening. What it does is prohibits cost sharing, but it doesn't change the current mandated prostate cancer screening benefit that's out there, which is one prostate-specific antigen test in a 12-month period for folks age 50 and over, or those 40 and over who have like a pre-existing condition or have risk on that. We've put this as yes, there is a mandate because under the state law, cost sharing is considered a mandated benefit in terms of it getting over here and coming to HERC to be looked at. But in terms of the cost of frail or what the feds would consider as a mandated benefit, this would not qualify as that because it does not change anything about the benefit that exists. It does do a little bit of moving around of the language, but not to any actual effective thing. It basically moves the definition of what prostate screening is to a definition at the beginning and then just refers to that throughout, but the language doesn't change within that. This can be, I guess this is actually not correct here. Because if it is just cost sharing, there's not, I'm sorry, yes, we can consider this through the step 2 process. What we can't do with this is send it to the EHB rebenchmarking because cost sharing is not a part of that. The EHB rebenchmarking is just about identifying benefits that are going to be covered, but not how they're going to be covered. So this bill can be referred for a step 2 process to look at the cost of it, but it is just changing the cost sharing so that that carriers can no longer have cost sharings on this. That is not currently what all the carriers do, but some carriers do treat this as a preventative service and provide it without cost sharing. But that is not currently required under federal or state law. So that's a choice that those carriers are making.
Mr. Chairman.
Yes, Senator Sproul.
Could I speak to the lady, ma'am? May I call her back to the stand, please? What's the name? Yes, ma'am.
Doug?
No, not Doug.
He don't want to talk. Oh, you want to talk to him?
You, ma'am. Yes, ma'am.
Ben.
Yes, ma'am, please.
Sorry, Senator Sproul.
Now, whatever he was talking about, well, does it interfere with what you're trying to do? Or you agree with it? Because I heard him say one thing, and I thought I was on target. Then he said something else. I'm off target. So whatever he was talking about, will that interfere with what you are trying to do?
I'm not sure I understand either, Senator Sproul. In other words, you're asking, is it the cost sharing question?
No, ma'am, I was trying to really understand. I paid attention to what you were saying, sir. But then you went to a second step as far as the cost sharing. Then I'm looking at step 2 that will be approved. Well, what he is talking about, will that hurt step 2?
Oh. Where's the chart? That's right here, right, Ben? Okay. This is a cost sharing bill.
Cost sharing, no benefit.
Okay. Cost sharing, no benefit. Now, Tom, please tell me if I'm wrong. If the HERC if HERC has looked at a bill like this in the last 2 years, such as House Bill 477, and makes a determination, then it wouldn't necessarily, if reintroduced, it wouldn't necessarily have to come back to HERC, would it?
Not under the statute. Certainly, the committee could send it back.
Could send it back if they want to, but would not be required to do so?
Yes, ma'am. Mr. Chair.
Yes.
Yes, ma'am.
So-
Mr. Chairman, that's a problem. Could send it back. And see, and that's what I'm trying to, I want to understand.
Now, this,
Sorry.
Okay, good, okay. All right, I'm satisfied, Mr. Chairman.
okay.
So Doug, you're still my friend. You're still my friend.
Okay.
I'm good, ma'am. Thank you so much. I'm good, sir. Thank you so much.
Absolutely. So the step two process on something like this that's cost sharing would really.
Don't mess it up. Don't mess it up.
That's
I'm
fine.
good.
I was just wanted to explain what that would constitute, that you could send this to step two, but what we would be looking at is really what would be the efficacy of removing the cost sharing, what would be the utilization with that, and what would be the cost impact of just that cost sharing component. So we wouldn't look at the impact of the entire mandate because the entire mandate is already there and existing. So
Yeah, and this is not a proton treatment.
that's right.
It's not any radiation therapy or anything else. It's just a blood test, so that's all that's done, so.
That's right. And it's a blood test that's been required to be covered since 1998. It predates ACA and all of these things. So it is grandfathered in and okay, and this doesn't change anything about that. It would just change the ability for folks to access it without cost sharing.
All right.
Thank you, Mr. Chairman. I thought Doug was trying to put a monkey wrench in here, but I love you, Doug. I'm leaving, so I love you.
Doug, sit down.
You should at least explain what it is.
Yeah.
I'm good. Thank you so much, sir.
So that's the end of my remarks on HB 477. Would you like me to talk about HB 240 as well?
Yeah.
Okay. Mr. Chair, HB 240 is about cost sharing for insulin. Part of the bill that's out there does create a discount insulin program. That is not what we're looking at here, although this part does, this section that has the mandate does reference that. But what it does is it amends the current limits on cost sharing from $50 per 30-day supply to $30 per 30-day supply for one insulin. Each carrier would have to carry one insulin product in each therapy category at that $30 per 30-day supply. They can also avoid that $30 per 30-day supply requirement if they cover at least one prescription drug in each therapy category under their lowest tier of drugs. So under the lowest tier of drugs where members would pay the lowest amount of cost share on that. Or if they guarantee that a covered person does not pay more than they would under that discount program that's being established there. So whatever that dollar amount would be established at that. So this is a mandate on cost sharing. It is not a mandate on any new benefits with relation to insulin. There is not an issue of cost defrayal here. Carriers did not indicate that this bill would mandate any expanded coverage at all. But that their cost sharing policies currently comply with the current law of the limit of the $50 per 30-day supply, not with the new law there. So this is also another that could be considered for step two, but cannot be sent over for the re-benchmarking 2025.
All right. Does anyone want to make a motion to have this one also go to step two?
So move.
All right. Yeah. Did we? Oh, okay. No, it is. It is. No. All right, we have a motion and a second on 477. Yeah. For step two process, so that there's calculations done there. All right.
Thank you, Mr.
All in favor, say aye. All opposed, no. All right. This will be recommended for, recommended for step 2 process.
All right.
Thank you.
And then, Mr. Chair, I'll hand off to Garth Shipman for
Yeah.
the remainder of the bills here. Thank you.
Right.
Mr. Chairman, members of the commission, Senate Bill 1301, House Bill 1871 deals with network adequacy for mental health services. The Bureau characterizes the bill as no mandate, believes it's setting the standards for administration of existing mental health coverages and services. The survey of the carriers indicated that they provide mental health services, but not to the level of which the bill requires. So we believe there's no action necessary for this one.
All right.
On the second bill, the House Bill 1538 and Senate Bill 1273, this was identified as a mandated benefit and mandated provider. So there will be some potential cost to frail depending on what direction is taken. There is no level of coverage of this on non-public plans for the doula care services. And there are the options you have going to step 2, considering it as part of the new EHB benchmark. You can enact it as a new mandate and pay the cost, or consider applying the coverage to the large group market. Any questions?
All right. Are there questions of the presenter here? No. So this is doula care.
Mr. Chairman, I have a question.
Yes.
This, and I know when we discussed this during the brief discussion on the bill, because we knew it was a mandate, was that doesn't this also bring into doulas that are not certified? Isn't there, or maybe there isn't a state certified definition? Is there? What?
No license.
Certification, no licensure.
Yeah, we don't have.
So I think part of the issue was more policy than it was anything else, was talking about the fact that we are trying to get insurance coverage for non-licensed medical services. So I don't agree with the policy, so wouldn't want to vote for it to go forward for until we have some kind of license or something that indicates a different level of service. But I don't know about the other members.
Right. Anybody have any questions, comments, motions? All right.
All right. The next one is House Bill 1918 and Senate Bill 1157, audio-only telehealth services. This, and this is for mental health services when there's no other means of real-time or for two-way audio, or visual two-way communication. This is a possible mandate. BOI looks at it as permitting another option for delivery of service. CMS has a very different opinion, as they view the bill as a new mandate in addition to the current EHB. So now you have a potential for a cost or frail issue, as CMS has objected to the definition of audio health as it's defined in the bill, as it creates a separate definition for telemedicine services. So you have your menu of options of step 2 or,
Mr. Chairman,
Yes, Senator Spruill.
now he's scanning mandate, possible cost. How much cost you talking about? You gonna mandate something, we want us to approve something on mandating something to the citizens, but yet we don't know how much it can cost that citizen. Mandate, how much you talking about? $1, $2, nothing? If you gonna mandate something, there's a cost to it.
and that would be found out in the step 2 process
Yeah.
if going forward.
If you want to get that information on how much it would cost,
I don't want you
step
to
2 is the process that we have available to us.
Yeah, okay, all right.
Are there any questions or comments or motions to be made?
I ain't voting for no mandate. I'll tell you right now.
Mr. Chairman,
Yes.
I make a motion to go to step 2 analysis.
All right, we have a motion to go to the step 2 consideration, the step 2 process, which would give us the fiscal information.
Mr. Chairman?
Is there a second to that motion?
Not really, Mr. Chairman, to the members. The key is this, when we do a mandate and we pass it on, then who we passing this mandate on to? How much it's gonna cost? At least we should have some idea.
Well, we would get the idea if we go through the step 2
I'm
process.
saying, but after the idea, usually when the idea is passed, it's the automatic thing that's going through. And I said, I don't want no mandate at all. I don't believe in mandates. So thank you.
Mr. Chairman,
All right, well, we have a motion and a second. We have to go to step 2 process.
Mr. Chairman.
Yes.
Discussion.
Delegate Byron.
Okay, so is telehealth a medical service that is available to, who is that available to? I mean, who would be in this mandate as being allowed to do telehealth?
As the bill defines it, the audio telehealth portion is available to those that can't receive the service through two-way audio-visual communication at that time.
So a nurse practitioner, a doctor,
So you're asking what
Yeah.
specialty can use it?
yeah, is it everybody?
That would be up to the practice
Mr. Chair.
and standard of care for that.
Delegate Byron, the bill says counseling interventions. So it would be those who counseling interventions are within their scope, but it would be limited to those services.
The bill only addresses mental health issues.
Oh, this one is just, audio telehealth is only for mental health issues? Okay, I'm sorry, I didn't catch all the details. Okay.
All right, are there any other questions or comments? Okay, we have a motion and a second to go to the step 2 process. All in favor say aye. Aye. All opposed, no? No. All right, 1 no.
Thank you.
Thank you. And health reinsurance, so you're back up, so.
Mr. Chair, members of the commission, I'm here just to provide a quick update on reinsurance. We don't have a presentation on this right now. With the manner in which things have been moving on this, trying to put it down into a presentation probably would have been being changed as we were walking over here.
That's right.
But
Well,
we did want
we
to.
got that bill, the budget adopted 2 weeks ago, so.
That's right, but not signed then.
No, it's been signed. The governor
Now,
signed it.
not 2 weeks ago.
Yeah, that was 6 days ago. So.
That's right. Yes. Now the updates that we have at the end are about the actual rates. So we do have those now for you all. We just wanted to update you all on the HERC or update the HERC on the Commonwealth Health Reinsurance Program. As a quick reminder, the CHIRP is a program designed to lower the cost of health insurance in the individual market by reimbursing carriers for a portion of their high-cost claims. The program operates under a federal waiver, and payments are funded largely, about 70 to 90%, depending on what level we choose for the program, by federal pass-through funding based on savings from reduced premium tax credits due to lower health insurance premiums. When we last spoke to you all back in April, we presented a range of premium reduction targets and associated funding levels for the 2024 CHRP. While funding for the reinsurance program for 2024 won't occur until FY 2026, the recently passed budget does contain language that directs BOI to continue the CHIRP for 2024 with a target for premium reduction of 15%, which is the same target reduction that we had in 2023. The total estimated cost to fund this premium reduction for 2024 is about $420 million, with about $66 million of that estimated to come from state general funds there. The BOI has worked with carriers to review and incorporate this information into revised 2024 rate filings that will include the impact of CHIRP on the rates for 2024. Those should be public this afternoon. But we can give you some preliminary numbers here, which is that prior to the reinsurance being affected there, rates were set to rise by 28.4%, and with reinsurance, they are projected to rise by 3.5%. And BOI would like to thank carriers for helping us and to get this information to us quickly after the budget was passed, and so that we were able to get this analysis done and get these rates out in time to meet our state deadlines on filing as well as our federal deadlines to put these rates out there. One other thing that we just wanted to address with the commission, or just put in your minds to think about it over the next session here as we get ready for the next session here. These health insurance premium rates are going to need to be set prior to the year that they're in effect, but the way that the reinsurance program works, the expenditures won't actually occur until after the year that they're in effect, and so there's actually a 2 fiscal year sort of break between when we actually need to select those rates and when we end up actually putting the funds into the budget to pay for them. As such, there's really no way the premium reduction level is going to have to be selected prior to even the governor's introduced budget for that fiscal year, just because of that time lag that's there. Without clear legislative guidance on a particular premium reduction or a funding level for a benefit year, SEC and BOI lack the necessary information to set the parameters and set those rates. As such, we just wanted to suggest the legislature might wish to consider creating a process or adopting statutory or budgetary language that directs the CHIRP to continue at a particular level. To sort of, I guess, to keep the legislature in the position of making decisions on how this program moves forward and how it's funded. It's just that it doesn't really work in the standard budgetary process, that we would just wait to see how much funding came in a budget and then set things, because by that point we're already past the point of having to set those rates. So that was all that we wanted to share with you all. Any questions?
Yes.
I just have a question. So can you just outline how we might improve the process? I mean, you just laid out that the reinsurance level needs to be set before the governor introduces the budget. Why is that the case? I mean, it seems like there's a long time between December and next July when the reinsurance rates would need to be transmitted to plans to actually estimate rates and whatnot. So
That's right.
Why
So,
is it so far in advance?
Sure. So if we look at, say, 2024, this upcoming year here, statutory requirements say that the Bureau is supposed to set the parameters for the reinsurance program in May, which then allows those reinsurance parameters to be included in the rate filing process that then goes on, and those rates then get announced in August for that next year. At that point, we're in August of, we would be in August of 2023 for the 2024 year. Those 2024 payments for that 2024 year will not actually be made till September of 2025, which is actually FY 2026. So they're actually, as we look at right now, there's not a governor's introduced budget, certainly not in April for 2026. That introduced budget would come here in the fall, and that would actually be too late for us to set rates for 2024 on. So that's what we run into there, is that when the program needs to be funded is fully 2 fiscal years beyond the fiscal year that we're in.
But, okay, so you're saying for '24.
Right.
But the introduced budget really should outline something along the lines of what should 25 and 6 levels look like. So looking far more forward, right?
I think that's what I think that is what the commission and the Bureau would like to see is, while the funding can't be there, the guidance can certainly be in a budget, in budget language there. And, anything that's statutory language to us. If it also could be in a statute, if a statute wanted to be out, if we want to put a statute out there that said the program will continue at X level there. But if we wanted it to be in that way that it's sort of fungible and able to be changed, year to year there, then I think probably budget language is the best way to do that. That being said, if the governor were to change something in the introduced budget, it wouldn't be until the following, the year, 2 years following, that we'd be able to sort of affect that change. But that guidance could be there in the budget, and we would certainly follow any statutory guidance that we receive there. It's just the nature of the actual funding, seeing that money there as general funds. It would either have to come a full fiscal year earlier than it actually needs to be there, which I don't think anybody wants to have to do there, or be in that position where the funding actually comes sort of after the decision is made on what the level of premium reduction is.
And last time around, CMS came back and gave us a higher federal share than was originally anticipated for this current year. Do you anticipate that they will do that again for calendar year or plan year '24?
So that result of that was a result of the effects of some large growth in enrollment, also some major program changes. So I don't want to predict the future and say there won't be anything of that magnitude. So it could change, and we won't get those numbers. We get the numbers from the feds in around April of the year that we're actually. So 2023, we got the 2023 numbers in April of this year. We'll get another set of numbers for that. And that'll be numbers that they base off of a submission that we send right now about our enrollment. So they're kind of making some guesses about what's going to be happening in the future. Their analysis is a bit of a black box to us. So trying to anticipate what that number will be, we can really only rely on what our actuaries set up. And they don't give us any insight into the underlying assumptions that the feds make as to getting to those numbers.
And is there any way to ask CMS, in the fall of every year to estimate where they think we'll be? Because we're about 3/4 of the way through their process, just to better line up with our state budget process. It would help to have some information or indication from CMS, even though it's preliminary, to base the cost of the reinsurance program. Because right, we have to submit to pay for that in the following fall for the prior calendar year. So just improving that process would really help. Otherwise, we'll end up in April and everyone would have guessed, essentially, in December and during the session. So just to try to improve that process, is that something that CMS would be open to, providing some information so we have something to go off of during session?
And Mr. Chair, to some degree, they are bound. We have to select our rates before they can. We have to select a premium reduction level, parameter level. We have to set our rates in the state, and then they want to see the latest set of our enrollment numbers, because what they're doing is using numbers we give them in September of the year prior to try and estimate enrollment for the entire next year, and then sort of basically multiply that by what the savings are month by month in premiums from our program. So we have to have our program parameters set for that year prior to them doing that analysis. And I think the reason that they want to wait slightly later, although I mean we're actually delaying them right now on those numbers because of the fact that
I don't want to belabor this. I'm asking if you can inquire with CMS.
We certainly can inquire with CMS and see if there's any way that they can potentially improve the process on our end from a timing standpoint.
Are there any other questions, comments, motions, et cetera?
Thank you,
All
Mr.
right,
Chair.
we're good, so. All right, next on the agenda is discussion of proposed legislation regarding commission membership. So right now, the law specifies that there are 10 members of the Health Insurance Reform Commission. 4 are members from the House Committee on Labor and Commerce, and the other 4 legislators are from the Senate Committee on Commerce and Labor. And in addition, then we have the Secretary of Health, the Secretary and the the Commissioner of the Insurance, yeah. Yeah.
Mr. Chair, given y'all's discussion on issues like reinsurance and defrayal on cost after
Yeah.
discussing with you and staff from money committees, this bill just proposes to add a member from the House Committee on Appropriations and the Senate Committee on Finance and Appropriations to HERC.
So there'll be a 10-member, if this were to pass. Huh?
Committee just for reinsurance.
So this is, we would go up to 10 legislators who would be on it, 4 from the 2 Commerce and Labor, or Labor and Commerce, and then 1 each from the House Appropriations and 1 from the Senate Finance and Appropriations. And so that will continue expand the number of legislators on the Health Insurance Reform Commission from 8 to 10.
Mr. Chairman,
Yes.
by adding those 2 on the from finance and from the appropriation, you're gonna mess things up. They're gonna get out here and try to run this damn thing. You're gonna mess it up. Don't do it. You can put them on there, you're gonna mess the thing up. You're doing finance, you got good members on both sides. But once you put a person from finance and put appropriation on it, you can turn it upside down. Don't y'all do it. I won't be here.
Mr. Chairman, they know how to pull our bills up to their committees when they want to, too.
That's all right.
All right. Does someone want to make a motion that we add 2 legislators, 1 from House Appropriations and 1 from Senate Finance and Appropriations?
I move that we don't do it.
Second.
All right. So does anyone want to make a motion to add?
You have a motion already. You already have a motion not to do it. So you're not paying that no mind?
No.
So I'm saying that how can you ask for a motion to put 2 on when you already have a motion on the floor not to do it? Unless you're just going to leave that alone and just do what you want to do anyway. You have a motion not to do it.
All right, we have a motion not to expand it. Yeah. All right. All right, we have a motion and a second to not expand the number of legislators on the Health Insurance Reform Commission. All in favor say aye. Aye. All opposed, no? No. All right. All right, what are the ayes? Raise your hand. Call the roll. So.
Delegate Ware? No. Delegate Byron?
No.
Delegate McNamara?
Mr. Chairman, what was the motion again?
The motion is to not expand.
To not expand.
Right.
Aye.
Delegate McNamara?
Yes.
Senator Surville? No. Senator Saslaw? No. Senator Spruill?
Aye.
Senator Barker?
No.
Ayes 3, noes 4.
Ayes 3, noes 4. So that motion fails. All right. Because Sullivan's not here. Yeah. Yeah. All right, that motion fails. Does anyone want to make another motion?
This is step 2.
No.
I move the bill be reported. Recommend.
Okay, the proposal is to recommend an expansion of the 2 people from the, reversing that. Would call the roll again.
Delegate Ware? Aye. Delegate Byron?
No.
Delegate McNamara?
No.
Senator Surville?
This is to recommend the bill.
To expand.
Yes.
Senator Saslaw?
Aye.
Senator Spruill?
No.
Senator Barker?
Aye.
Ayes 4, noes 3.
Ayes 4, no 3, that passes. So, all right. Thank you. All right, and then we have public comment. Okay. All right, and we have, up here, we have written communication from the Susan G. Coleman, and which we were dealing with on one of the bills, 1815. All right. Is there anyone who wants to testify? Okay, come forward.
Good afternoon. Thank you for having me here. Thanks for having public comment. My name is Ayala Sherbo, and I live in Lovettsville, Virginia. I'm here with a friend, Teresa Champion, and we're here today because we don't yet have a bill in front of the General Assembly, but we hope to have one next session. I want to tell you a little bit about the illness that the bill will be about. 9 years ago, my youngest daughter went from being a normal, happy, active 8-year-old soccer player and kid who loved school to a hysterical, almost feral child who refused to bathe, refused to change clothes, refused to eat almost anything, refused to leave the house, and refused to go to school. I had to withdraw her from 4th grade. My family was fortunate in that we had the resources. We had good health insurance. My husband made enough money that we could live on one income, and I was able to dedicate myself to her care. Even with all of those resources, it took us 8 years to get the right diagnosis for our daughter. 8 years of trauma for her and our family, 8 years of lost educational opportunities for my daughter. Now at 17, she only has an 8th grade education, despite always qualifying for honors classes whenever she can be in school. Finally, at the age of 15, my daughter was diagnosed with PANS, and we could begin to seek treatment. That treatment was not covered by insurance, and it has cost us so far tens of thousands of dollars out of pocket, and she is not well yet. Our story is not unique. This disorder can and does happen to any child at any time and can be triggered by something as innocuous as a case of strep throat. The disorder is not static. When children aren't treated, they get worse over time. Early intervention is the key to successful healing and getting our children back and engaged in the healthy development that we want from them. There are treatment guidelines for these disorders. Insurance just does not cover them, and too few medical professionals recognize the symptoms. PANS and PANDAS are immune-mediated disorders in which the child's immune system attacks healthy brain tissue, resulting in life-altering brain inflammation. This disorder can and does happen to any child at any time. I left a piece of paper that had the symptoms. Can I just go read the symptoms really quick to you? It's like one more paragraph. The symptoms of PANS and PANDA vary from child to child, but this is what you typically see, and my daughter had all of these at the same time. They include obsessive compulsive behaviors, restrictive eating, tics, intrusive thoughts, irritability, depression, cognitive decline, learning difficulties, headache, nerve, muscle, and joint pain, severe behavioral issues, anxiety, insomnia, loss of motor control, and urinary frequency and incontinence. As you can tell, this is debilitating and derails children from healthy development. Thank you for your time.
Good afternoon, Mr. Chairman, members of the commission. I'm Teresa Champion, and as a follow-up to Ayala's testimony, why are we here today and what are we asking for? Well, next, we hope to have an insurance bill in the next session. And this is going to be a part of a foundation that we're trying to build for families with this diagnosis. Insurance coverage for private insurance, and that's why we know we'll be coming to the HERC. Medicaid recipients also need this. This is important for families who can't afford to pay out of pocket. We also are asking, as a part of this foundation we're building, is the reestablishment of the PANS Advisory Council. We actually have that in Virginia, and it made great strides in 2017 through 2020. However, due to COVID, it was unable to deploy all its assets to the medical and educational community, and then it sunset. So we need to include the council in legislation so it doesn't automatically sunset and it can continue its mission of awareness and education. We want to educate families about the diagnosis and symptoms so they're aware and they can seek treatment early. We want to educate doctors and nurses and other medical professionals so they're aware of this post-infectious neuroimmune disorder and are able to diagnose and treat or refer. We want to educate other medical professionals on post-infectious neuroimmune disorders, and the council can help us do that. We want to ensure that information is distributed to professional groups encountering patients and students with this diagnosis. We want to encourage research, Virginia's collaboration with ongoing research studies and treatment. We want to encourage improved access to care in Virginia so that families don't have to leave the state, permanently relocate in order to access trained medical care. We are ready. We have spoken to every state that has passed similar legislation. That's in this folder. We've spoken to researchers and doctors across the country that treat. We've attended numerous webinars, and we're raising money for the Neuroimmune Foundation so that Virginia doctors are going to be able to receive free CMEs on neuroimmune, post-infectious neuroimmune encephalopathy and other similar disorders. So we're raising money so that doctors can receive education and learn about the most current research. We're ready. And we are going to be asking for PANS legislation in the next session. Thank you so much. And I'd like to find out if I'm going to be the last public speaker in this building. Am I going to be?
Possibly. Mr. Chairman, I would remind people here today, both here and in the audience, that Mrs. Champion has been the motivating factor on why there's insurance coverage for children with autistic problems.
Thank you, Senator. Thank you.
Yeah.
Appreciate your all's help.
Is there anyone else to testify in public comment? All right, is there a motion to adjourn? All right, is there a second? Okay. All in favor say aye. All opposed, no. Okay.